All right, so IV titrations. So we are looking at, basics, what to do, what best practices are, like independent double checks and, how to scan your bags, how to make sure that you have the right concentration, all these kind of things that are basics, make sure the weight's accurate, making sure the order is good. And then we're going to move on to like pressors. What are the vasopressors? And we've been kind of touching base on a few of these. We've kind of been introduced to some of the physiology with CHF and hypertension and, alpha receptors, beta receptors, right? Vasopressin receptors, angiotensin 1 receptors. All these different things are going to be interacted upon by pressors, right? They're going to work on these appropriate ones that are going to cause vasoconstriction if it's a vasopressor, right? And then we'll talk about some other drips, such as like insulin drip. We'll talk about like Protonix drip and octreotide drip and diltiazem, amiodarone. So some other things that don't kind of fit in their own category, including antihypertensive drips. And then we're going to finish off with sedation. And we kind of been touching base on sedation and respiratory, but we're going to go into the actual agents. So in respiratory, you learned about how to titrate or how to interact with them and what how much sedation to provide and everything. But now we're going to go into deeper as far as which ones cause pancreatitis, which ones cause bradycardia, which ones cause a high anionic metabolic acidosis because of the preservative that is mixed in. All right, so we're going to talk about all these things today. All right, so what is a drip, right? So drip is abbreviated first of all as GTTs. You'll see that frequently. All right, so we have a drip that is either fixed rate or titrated. So as I mentioned, the fixed rates are going to be the ones that kind of fall in the other category usually. You got a fixed rate of amio, I got a fixed rate of diltiazem, I got a fixed rate of octreotide, a fixed rate of dobutamine, for instance, right? These are fixed rates. In shock states, we do give vasopressin, as we mentioned in shock and septic shock, that vasopressin and norepinephrine, one of our pressors, is very, very synergistic. They're going to work great together, and they're going to really escalate and hopefully raise our blood pressure, right? And it's a fixed dose, in septic shock. They found doing higher doses cause bad outcomes. It causes GI collapse or GI ischemia. So if you have a GI hemorrhage, though, it's like, well, are you going to die from hemorrhage or GI ischemia? So in GI hemorrhage, we're going to titrate that bad boy all the way up, right? So like 0.03 and all the way to like 0.1. It's not that much, but still, we're not going to go any higher than that. Okay, so we mentioned amiodarone is a fixed rate. We've got diltiazem, heparin. Yes, it's titrated. You're adjusting the dosage, but it's not used. Like, yeah, we're going to go up by 15 units per kilo right now. No, you do that based on a PTT value or an APTT value, technically, right? So that's titrated technically by pharmacy, right? They're the ones that tell you how to titrate. That's why heparin can be titrated on the floors, right? Heparin's an okay drip to be on the floors, right? I was told by a supervisor recently, it's like, oh, why is he put the heparin patient out on the floor? It's like, we're not titrating. Pharmacy titrates it. That's not something that's okay. It's okay for them to adjust it out on the floor. There's nothing the nurse has to do except for do an independent double check to make sure that what pharmacy wrote is true and make sure the PTT is accurate and everything's in the right space, right place that it needs to be in. Okay, and then diltiazem, yeah, it's fixed, but I consider it fixed because there's only 3 titrations you can be. It's 5, 10, or 15 milligrams per hour. So technically, yeah, how much titration is there? Right, you titrate a heparin drip more frequently. So diltiazem is it is technically titratable by default on our default titratable table, which I gave you a printout of, right? That's color-coded one here, right? So these, I think a light pink is the color I chose for cardiac or for arrhythmias at least. Dark red I chose for paralytics because you don't want to mess up a paralytic and an antiarrhythmic, right? So dark red is caution, right? I have a paralytic and I need to titrate it, right? You can't just titrate a paralytic. Like, yeah, they need to be more paralyzed, right? So we have different tools that are used that can tell us if someone's is responding or not responding, and if we have to go up with the medication or not go up with the medication, right? So the joint, right? That hasn't caught on yet, but I keep calling them the joint, right? The Joint Commission. All right, or JACO. The JACO acronym never made sense to me because I couldn't find the A. The A and the C were switched. It screwed with my brain. Anyways, we have the joint. They define a titratable medication as one that you are progressively increasing or decreasing, right, based on a patient response. So here's the therapeutic effect, here's our response right here, right? And as I titrate up this medication, I go from 2 mics to 4 mics to 6 mics to 8 mics to 10 mics, and eventually I'm going to get a good patient response, right? But lingering right behind is the side effect, right? So the side effect can sometimes creep up right along with it and cross it, and the side effect can be very, very deleterious, right? Such as like dopamine. Dopamine is going to raise your blood pressure, but you're going to have VTAC at the same time, right? Because it's very, very arrhythmogenic, right? It's tachyarrhythmogenic. It really generates tachyarrhythmias, such as VTAC, right? So of all the things we've learned about hemodynamics, we didn't learn about ECMO yet, right? So we got ECMO device right here. We got some different other pressure bags, might be a little bit of hypovolemic shock going on. And what we're talking about today is just a little tiny little piece right here, the titrations, right? How to titrate up and down based on patient response. All right, so a complete drip order. So in green here, this is what is there automatically. So that little cheat sheet I gave you with all the tables, right? And so we have a crafty person up here who's going to give you a little badge buddy as well that shows you, you can kind of reference which one, the common drips. But the starting, ending, and max dose, that's all been decided by corporate, and they've said, hey, for corporate pharmacy, this is what we want our drips kind of be starting at, right? This is what the default order can be. Does that mean you can change it? Absolutely, you can change it, right? Can you change it just because you feel like it? No. You need a provider to change the order for you. That way you can say, hey, this max dose is not working. Can we go up? And in vasopressors, you can go higher than the max dose. You just have to have the provider's order to validate it, right? So titration parameters, they'll tell you, the order will tell you what is the starting rate, right? How do I start this at 4 mics or 2 mics, right? And if I wean someone off a medication, I go from 6 mics to 4 mics to 2 mics to 0. And then I say, oh, shoot, blood pressure's still low. I'm going to go back on my norepinephrine, which usually titrates at around 2 mics per minute, right? And then so you restart it back at 2 mics. I went to 0, it makes sense to go right back up to 2 mics. But no, the default order says start at 4 mics. So that's a problem, right? That means you're not following the doctor's orders. You're not, what are you doing? You're trying to do medicine here, right? So that's, you have to pay attention to that starting rate. That starting rate is every time you start the medication from off to on, basically, right? So if you titrate the medication all the way off, so they don't need 4, right? They just need 2. What are you going to do? Your doctor's order, change the starting rate to 2, right? That's the easiest thing to cover your butts, right? It's your initial dose, okay? And then every Thursday, this changes. So the starting dose next Thursday could be 2.5 mics, or start at 2 mics, or start at 3 mics. So you have to verify your orders on handoff. On handoff, you're looking at all your orders for all your drips. For my propofol here, I'm looking at my norepinephrine here, I'm looking at my fentanyl, I'm on a sedative, a pain medication, and a pressor, and I got to know what I'm titrating on for the day or for the shift, right? So every Thursday it changes, because like I said, it's changed from 0.5 mics by every 5 minutes, how we can titrate Levophed, to 2 mics. That happened on a random Thursday when the Joint Commission was here, right? So that was a meeting of the crossroads of unfortunate events, because now the nurse is like, oh, I go by 2 mics. Of course I go by 2 mics, not 2, 2, 2, 2, 2, 2. And then the Joint Commission is like, well, what does your order say? 0.5. So, oh shoot. All right, so how am I going to take that back? I can't take it back. It's looking at the charting from the previous day, right? So you got to make sure your order is accurate, basically. So we got the starting point, we got the ending point, right? What's your max dose? So Levophed at 47 mics, and you're gonna learn this over time. Why is it 47 and not 45? Why is it not 50 and 47? Right? Because they're not an ICU nurse and they don't have OCD. That's why. So because Levophed also dosed sometimes per kilo, right? But we dose it here as mics per minute. So other facilities might dose it mics per kilo per minute, and so we got to recognize that. So they chose a random person that weighs 47 kilos, so 1 mic per kilo per minute is usually the top end of norepinephrine, so that's what they chose, 47. Right? I don't know how they came to that, because I don't know what kind of weight patient they were looking at, but it is dosed per weight or dosed per minute. All right. So how to get to the max dose? So we know what the max dose is, 47. Do I go from start at 4 mics and go to 47? No, I go by a certain increment, right? So I increase the medication, I look for an effect, no effect, I go up a little bit more, or not the effect I want, I go up more, right? So that is the titration increment. That is how fast I'm going up on the medication, right? So this says 0.5 is how fast you're going every 5 minutes, right? So why is it 0.5 and not 2? Well, why is it 2 now, and was it 0.5 before? Because don't want to admit they're wrong, but 2 mics is the appropriate amount to look for the half-life of the medication, right? Why is it 5 minutes? Because that's how long it takes for it to wear away, right? I don't want to go up and then go up and go up, and all of a sudden all the medication is accumulating because I didn't wait for the half-life of the drug, right? So the half-life of the drug is what matters. That's what's going to tell us how frequently do it and how much, right? Those are been calculated on the back end for you, right? Yes, I go by 0.5. I could technically go up like every 1 minute if I wanted to, right? Because it's based on the half-life of the drug itself. So how often? Again, that's based on the half-life. And then the objective clinical parameter. So what are you titrating this to? Are you just going up by 2 mics just because you feel like it? Or are you going to based on a blood pressure, for instance, right? The fentanyl. I'm going to go up on my fentanyl because I have a CPOT score or a numeric pain scale of X, right? Someone has a paralytic infusion, I'll be looking at my train of 4 and my BIS monitoring. Someone has a like a norepinephrine, I'm going up on norepinephrine because my SVR is really low, right? Because SVR is how much vasoconstriction there is. If going up on my dobutamine or my milrinone because my cardiac output is less than 2.2, right? So I want to go up on that because I have cardiogenic shock, and that's defined as less than 2.2. So I'm going to, and they're like 1.8 on my last cardiac output measurement, so I'm going to go up on my medication that's going to increase inotropy, right? And go down on medication that's causing too much vasoconstriction, for instance. Okay, and what's RAS for? RAS is for your sedation. So you notice here we got titrate to RAS. How much RAS? This is -4 RAS, right? And as we'll find out, -4 is pretty deep sedation. Usually RAS is what from our pulmonary lecture? 0, -1, right? So those are all there by default. Now what's up to you to recognize in your orders is to figure out what is if I do got 2 medications for the same thing. I got propofol and Versed, or propofol and midazolam, right? Both of those are for sedation. So which one to go up on, right? Propofol tells me 5 mics every 10 minutes, and midazolam tells me 0.16, what is it, 0.025 or something weird, all right, every 15. So which one to go up on? I got both of them available to me. They're both infused when I came on. Which one to go up on? So that's where we have to have dual infusion instructions, right? Or in a better example is I have like norepinephrine. I got vasopressin, which is fixed. I'm going to wonder about that. But now I'm patient sicker. I'm on a third pressor. I'm on neosynephrine, right? So I'm on neosynephrine and norepinephrine. And which one to go up on? Do I go up on the neosynephrine? And then when I hit X amount, do I go up on the norepinephrine? What do I do? So these things need to be clear in our instructions. So the dual infusion instructions need to be clear. So say, hey, when you get Levophed at 20 mics, go ahead and start your neosynephrine. And when the neosynephrine is maxed, go ahead and start epinephrine infusion, right? So that is 3 medication orders. If they have something for the same reason, you have to have a dual titration instruction, okay? Sometimes there's rescue titrations that says like, hey, if your blood pressure drops less than 90, you may increase by 4 mics instead of the traditional 2 mics every 5 minutes, right? Those are like rescue titrations. But basically we have to have coverage for ourselves, right? You can always do a plain nurse communication order, say increase Levophed to 15. That's fine, right? But if if it's a common thing, we can even put it in the instructions. Okay. So example. So it's using our medication, our initial dose, our dose increment, how often, right, and our objective endpoint. So this was propofol. Propofol is our medication. We started at what? 5 mics, right? And we titrate by how much? 5 mics. By how often? It used to be 5 minutes, but then someone upstairs in corporate and pharmacy does not have OCD. They're like, how about 10? It's like, what are you talking about? 5, 5, 5, 5, 5. What are we doing here, right? So 5 is perfectly fine, but someone decided we're going to do 10, right? So every 10 minutes, right? And if you want to have the OCD checked, you can change it back to 5. I'm just kidding. Right, so make sure your orders all line up so everything looks nice. Right, my Levophed is going to 50, my propofol is at 5 every 5. We're all good, right? So yeah, so how often? Every 10 minutes. Why? Why not every 2 minutes? Because you'll build up propofol too quickly and you'll have the side effects of propofol, right? And then what's our endpoint? What are we titrating to? I could go up by 5 mics every 10 minutes, no problem. But what is it titrated to, right? And that's to a RAS, right? RAS of 0, -1. That's where we want for most sedation. The only time you have a RAS that is deep is if you have ventilator desynchrony, or you have seizure activity, right? Or you have someone on paralytics, right? Where we want to have deeper sedation. Okay, and then of course our max dose. How high can I go? Okay. All right, so what else? So that's our example, and then we got rescue titration. That's if your patient gets really sick really quick, their blood pressure is all of a sudden like 40/20. You're like, oh yeah, 5 mics. I'm going up, so let's say 2 mics. I'm going every 5 minutes. It's only 5 minutes. Blood pressure's 20. What do you do now? I gotta wait 5 minutes. All right, leave me alone. I got 5 minutes. I'm gonna do some charting. I'm gonna go to the bathroom and get some peanuts. We'll be back in 5 minutes. Then we'll go up by 2 mics if we need it. Right. So we have critical thinking, and the Joint Commission recognizes you have critical thinking, and we should be able to rescue our patients if they are decompensating acutely in front of us. Right. So someone that's crashing. Of course, you can notify somebody, get someone to the bedside, so you have support. When you get more experience, you're gonna tell them what you did. But when you're younger, you're gonna tell them, hey, what should I do? And they're gonna do this, this, and this, right? So you're gonna say, notify the MD for possible change in antibiotics, something stronger, right? If something, you might have to add some more pressors, you might have to get a little more fluids. So there's some other things that they can do at the bedside to add to the puzzle for you. Otherwise, it can be a rescue titration. Say, hey, we'll go up to max the Levophed to 47 mics. So you're gonna put nurse communication max to 47, right? You can put a comment on your titration documentation, but that's not an order. That's just a comment of what you did. You have to have an order to back up what you're doing, right? So you can do that, or we can do what's called block charting. So block charting is something the Joint Commission came up with, and it tells you, it gives you a 4-hour chunk to chart what happened, right? Say, hey, my patient decompensated for these 4 hours, and this is what I did. I started here, ended there, maxed it here, and I was titrated by this frequency. So it kind of gives you a little ballpark estimate of what you were doing for a 4-hour chunk, right? In our Cerner system, we have iAware, and iAware is very beautiful. You can do like second-to-second titrations, and has all your data saved, so it's easier for that reason. But not every system, every hospital can afford a $2 million EMR, right, per year. So they have to then, sometimes people are on a different system, right, like Meditech, right, which is like an Excel sheet, right. So that's so they can't really get that minute-to-minute interaction. They don't have Wi-Fi that'll connect their Alaris pumps to their EMR, right. So that's where the Joint Commission says, okay, then you can use block charting. All right, we can use block charting as well. Okay, all right, that makes sense. So we got our initial rate and our restart rate. We got our half-life of the medication, how often we're doing it, right? We got our concentration, which can change, right? Sometimes the providers in their office, they say, hey, I know there's a little fluid overload. Instead of 8 and 250, let's do 16 and 250, 16 milligrams and 250. That's a more concentrated solution, right? So if I'm still going, I just spike the next bag, right? Spike it. Is that going to deliver too much? Going to deliver more medication to the patient or less medication to the patient? If I just kept it the same rate as going up before, and the concentration went up, what will be the end result? You have more medication because there's more milligrams or micrograms per cc in a 16 and 250 compared to an 8 and 250, right? And we'll talk about that when you have increasing concentration. You got to change the whole tubing because you got about 20 cc's of tubing before you actually have that change occur, right? So looking at our dose is important because often that happens in handoffs. Like, oh, why are we doing 16 here, right? The order says 16 and we got 8 hanging, or vice versa, right? All right, any of these can be changed with an order, right? You can always have these changed by 4 mics, for instance. Hey, my map's 50 to 65, titrate by 4s. If your map is less than 50, titrate by 8s. Yes?
So is it good practice to get rescue titration parameters on all your orders in case?
It depends on the patient. I mean, your patient is just coasting on like 8 mics Levophed. Sure. No, not really. But like if it's a dialysis situation, right? It's like, yeah, I'm going to have some dialysis stuff in here. Like every time they go on dialysis, their pressure dips down to the 70s, okay, gotcha. Right? So I say, hey, my map's less than 50 or less than 65. Go ahead and titrate by 4s instead of 2s, right? All right, so rescue titrations and block charting, right? So like I said, you can make a comment, right? You can go into iView. You can say, per Dr. Ahmed, increase the Levophed to max, right? Then max being 47. But that's not an order, right? That's not an order that goes to their system and that they then sign off and agreed upon, right? So they're going to look for that. The Joint Commission can come in and say, hey, why'd you go to max right here? Are you just doing what you want? No, I got an order. It's like, well, where's your order at, right? So you have to have a nurse communication order in there. Okay, and just doing the documentation where you notify the provider, that's just a notification, right? Documentation. That's not telling the system or telling the universe that you have an order for it, right? You have a literal order in there, max Levophed to this, right? So make sure your orders reflect what you're communicating, right? You want to be able to communicate what's going on. You want to have that documentation that I let them know about this, let them know about this decompensation, let them know about this, and this was changed, that was changed, right? I maxed it here, I diminished it here, but the actual order needs to be changed, or you just do a quick nurse communication, max leave fed, right? And then we have block charting, right? So block charting is where you are, the Joint Commission says, hey, tell me what you did in that last 4 hours, right? What if 4 hours goes by and I'm still have an unstable patient? That can happen, right? So then you just do another 4-hour chunk, right? But basically what you're telling them is during a 4-hour chunk, what's the timing? So it was from 1:30 to 3 o'clock, 90 minutes. I was doing all kinds of fun stuff. What fun stuff were you doing, pray tell, right? I was going on Levofed, and I started here, stopped it here. I started propofol because they're trying to move all over the place. Started here, stopped it here, and then I started, vasopressin as well, and I started phenylephrine, and I started it here, and I maxed it a little bit for a little bit. Then I went down to, and I ended at this rate, right? So I get the time, what I started and ended at. I have the drips that I used, and for each drip, you have a little block chart, right? And what was the starting and ending rate for each one? Did I hit the max rate at any time? What was the max rate I achieved? So propofol and was hit up to 45, and we ended at 30, right? And then what were the goals? What were you titrating to? So for my pressors, obviously probably a MAP of 65. My sedation was a RASS of 0, -1, or maybe it was deeper because they were very hypoxic. It was like RASS -3, -4 even. Right, so that's an example of block charting, right? And how do you do block charting? So iView is not designed for that, right? So you can put a comment, and yeah, you could fit block charting there, but you're just doing little progress notes. So you hit a progress note in the system, like a narrative note, and you're going to include all these things. Well, what if I forget something? Well, that's where we got you, right? So you type at RN, and automatically get a dot phrase or a auto text that will pull in all this stuff. And now you just change the blanks to what you need to change it to, right? And you do that for each one of your medications. Does that make sense? So that's what block charting is, that you are charting on a medication that you're going outside the normal default parameters, and you're going to tell us what you did. What did you start at, stop at, what was the max that you had, and what were you titrating to? All right, so then weights. So shifting gears to weights. So some medications, some IV drips are weight-based. So you got to make sure you have the right weight that you're titrating to. And there's all kinds of weights out there in the universe. So these are the weights that we have. We have ideal body weight, adjusted ideal body weight. Kind of think of it as the same thing. And then you have your actual body weight, what someone actually weighs in front of you. And then we have the dosing weight, which is what pharmacy doses on, right? That's usually what we are going to be titrating to. But there are some medications that are ideal body weight, like heparin is ideal body weight, right? Because you don't want to do actual body weight because you're going to give too much heparin. If you give dosing weight, you might give too much heparin also, right? So these are things that we have to think about when we're doing our daily weights. And how often are daily weights done? Daily, right? We say it all the time, but it doesn't happen, right? So to make sure your daily weights are done daily, so we can then think about, do we need to change the dosing weight, or should I keep it the same, right? So going back to the top, so we have meds that are based on the ideal body weight, right? What should a patient weigh based on their height and based on their birth gender? So we use ideal body weights a lot for like tidal volumes, right? But you might use ideal body weight for like heparins. So you're looking at what their height and gender is, and then that is going to be their ideal body weight. That's how we're going to dose it, right? Dose this medication per kilo, but it's not the kilo of what they weigh in front of you, it's what the kilo what they should weigh, right? But what if they're more than 30% their ideal body weight, right? Their actual weight, 30% more than they should be. Then we'll use adjusted ideal body weight. This is for obese patients, right? So ideal body weight and adjusted ideal body weight are the same. They're both based on their height and birth gender, but one is for an obese patient and one is for a non-obese patient. All right, then moving gears to actual body weight. So this is their daily measured weight. And how you know that weight is accurate? Well, you got to make sure you've tared things that you're on your bed, right? So hey, my bed without the patient had a sheet, it had a chucks, it had an SCD machine, and it had all these TTM pads, let's say, right? Or it had this continuous passive motion device, right? So then we're going to tear those things out. So now it's 0, and we're going to then say right on the whiteboard what it's zeroed with, right? We have a standard script, but what we do here, right? So one top sheet, one draw sheet, one chucks, one pillow. That's it. Right? If it's more, you got to write on the board what else you zeroed it with, right? Because otherwise, someone in the morning is going to take off the SCDs and hit weigh, and now you're adding or subtracting weight, right? So what else on this piece? So the actual daily weight is done, of course, same day every day with the same things every day. And then we're going to be charting this in the computer. It's only informational until it's not. So until that daily weight actually has a significant change from when they came in or from the last 7 days, then we're going to start, changing some other values. All right. So it's never used for medication administration. That's not a thing. You're not going to use that after day 0. Day 0, when they come in, that's your daily weight and that's your dosing weight. That's what you're going to dose them with. But after that day 0, you're not going to be changing your IV pump every single morning. Say, oh, they're 80 kilos, they're 81 kilos, they're 83 kilos, they're 84 kilos. You're not changing that every day. You only change this dosing weight when they have a significant change in their daily weight. All right, so what is a significant change? The significant change is every 7 days, right? So so they had they've been here for 7 days. They came in, they're 80 kilos, and now they are 76 kilos. So we're going to change that to every 7 days. And what if something else happens? They have a 10% change in their weight. So what's a 10% change from 80 kilos? 8, right? So 10%, just move the decimal over, 80 to 8, right? So 8 plus or minus 8, right? So if they go to 79 kilos, well, shoot, or sorry, 89 kilos, well, shoot, that's 9 kilos, that's more than 10%, right? Or they went to 71 kilos, right? That's more than 8 kilos, right? So a 10% change up or down is a time when you change this, right? And we're not all the best at math, so the computer will actually do it for you. It'll say, hey, you got this percent change. I'm not sure if it does 7 days worth. I think it does based on your last one you inputted. So you have to look at that to see what kind of change they have. And then, yes, now we're going to change that weight on our pumps, right? So the daily weight will change, and we can also look to see how much fluid balance they've gained or lost as well, right? Because every kilo change is equal to how much? About a liter change in a fluid, right? So it doesn't lie. So we can lie and forget to chart our I's and O's. It's like, oh, I forgot to get that last 6 o'clock Foley catheter output. But then the next person forgets, and the next person after that forgets. But the daily weight's not going to lie. It's going to say, oh, you gained 3 kilos, right? You gained 3 liters, even though the I's and O's don't reflect that. Okay, so all dosing weights are what are called measured. So in Cerner, you can indicate if something is a estimated weight or a actual weight, right? So these are going to be measured values. All right, so same time every day, right? Same weight state on your daily weights, and then you only change your dosing weight when you have a 10% change, or every 7 days. So you can see here up top it says stated. Is that right? That's danger. That's what they are estimated, right? So the EMT comes in and they say they're $150, or they're 150 pounds. So it's like, well, okay, they're 76 kilos. And so is that their actual weight? No, it's not their actual weight. So this stated should always be changed to a measured weight, right? You want to measure what they are when they come to us as a new admission, and also every day at what time? About 5 a.m., right? With the same things every day. Okay, so measure weights are done daily, and then we'll change the dosing weight if that's a 10% change, or every 7 days. And how do you do that? So you've documented it, fine, and you're gonna change the dosing weight right underneath your daily weight documentation. So it says daily weight right here, and it says, hey, you got 7% change from the previous. Doesn't really tell you like the last 7 days, but anyways, the next piece here is your dosing weight, right? So you can change the dosing weight at that point. And then now you have to go back to all your drips, and you have to modify the drips to change the weight that it's based on, right? Otherwise, you get a double check from your other nurse when you hang a new drip, a new bag. It's going to have the wrong information there, right? Especially if you have your pump programmed correctly. So you change all your pumps and you change all your orders to match. And this makes sense. I only want to do this every 7 days, right? I don't want to be doing this every single morning. This could take a second to get all that upkeep done. Okay, does that make sense as far as how to change, what the difference is between a daily weight and a dosing weight, right? Daily weight is done daily, dosing weight is not done daily, right? But you're going to assess it daily if it needs to be changed.